So our final speaker today is Camilla Kingdon. She is a consultant neonatologist, also from the Evelina Children's Hospital in London. Camilla's interests include team morale, medical careers, and finding joy at work, and she's going to talk to us about prematurity for the acute paediatrician today.
Yeah. Thank you very much indeed. So, I, like Mike, have been able to wander over Westminster Bridge after my safety huddle on the neonatal unit this morning. That's where I work at St Thomas's Hospital. So the neonatal unit is based within the north wing of the hospital, and that's the children's hospital, which is separate but on the same site. And that's kind of where all the fun is to be found. And I think this is the problem with neonatology, is we sit on our neonatal units for very justifiable reasons. We're behind kind of closed doors, next to maternity, strict hand washing. I mean, we are lucky we have a really decent view. We can see the London Eye, we can see the river, but we're kind of hidden away there. So I'm really grateful for the opportunity to be here today as a neonatologist, and I've come with two messages for you. The first message is that there's a lot of good news about outcomes for babies who are born prematurely, and I'm going to tell you a bit about that. And my second message is that you guys have a vital role to play in making this an even better story over the fullness of time. So, in the UK, we had a review of all neonatal services nationally in 2018, and actually the conclusion was that this is a good news story. Last year was the 70th anniversary of the NHS, and actually modern neonatal care is one of the greatest success stories over the last 70 years, and the outcomes for newborns in this country are as good as anywhere else in the world. So I'm going to show you what I mean by that. So here's data that's around looking at survival to discharge in babies between 23 and 25 weeks gestation. I've pooled the data between UK data based on the Epicure cohort, which you may have heard of, where we looked at outcome in 1995 and then again in 2006. And I've merged it with some data from Sweden, because Scandinavia is always quoted as having, the best outcomes for everything, and a North American data set. And I think it's easy to see that across those extreme degrees of prematurity, there's been a steady sequential improvement in survival to the point of discharge. And I think on the face of it, that's a good news story, but some of the cynics sitting here may be thinking, yeah, that's all very well, but what kind of state are they in when they go home? And I think that's an important question. It's a really important question for us neonatologists. Understanding the burden of disability is absolutely crucial. So disability, and this is severe disability, here are the figures for that same data set. So you'll see at 22 weeks, about a third of children are severely disabled. And by that I mean they're non-ambulant CP, have non-ambulant CP, or they're blind, or they're profoundly deaf. But you can see by the time you get to 26 weeks gestation, really it's down to 10% fall into that category. And if you flip the data around and think of it differently, a third of our babies born at 24 and 25 weeks gestation are actually entirely normal when they're assessed at 3 years of age. So I hope, just with this kind of brief snapshot, I've given you some evidence to consider to back up my theory that actually I think neonatal care has been a huge success story over the last couple of decades. But it hasn't happened by chance, and it hasn't happened just by what we do on neonatal units. It's happened by concerted, organized change across lots of professions and more widely. So it's about obstetric care, it's about the organization of healthcare services, it's about the third sector and collaboration with parents groups like Bliss and Best Beginnings and so on. So I just want to give you a couple of little nuggets to show you what we've been doing. So in terms of our collaboration with our obstetric colleagues, I'm sure you're all well aware of the routine use of antenatal steroids to enhance lung maturity. But we now also have the routine use of magnesium sulfate. So any woman at risk of delivering before 30 weeks gestation will be given a dose of magnesium sulfate. We don't understand how it works, but it's neuroprotective. So the combined effect of these two is going to be fascinating to follow up over the next 5 to 10 years. So there's some really interesting work looking at magnesium sulfate in the mother. Organisation of care. This is a really thorny issue because this is about reconfiguring services, and nobody wants to work in a hospital that's being reconfigured. However, in the UK, we have set ourselves up into 15 neonatal networks. And the goal is that 85% of babies born less than 27 weeks should be born in a tertiary neonatal unit. That's a neonatal unit that offers wrapped around perinatal care and intensive care. In fact, looking at our data set from 2017, only 2 of the 15 neonatal centres are currently delivering that standard of care. So there's still a huge amount of work to be done, but the work's begun. What about, what are we doing with lung disease? Loads of stuff is happening, and it's small, incremental things that are starting to improve outcome. We know about 1/3 of babies born less than 32 weeks will go on to develop chronic lung disease. That's some form of dependency on oxygen or some form of ventilation at 36 weeks corrected gestational age. So there's some really interesting work happening around surfactant use. So those of you that are currently working on neonatal units, you'll be aware of prophylactic surfactant, minimally invasive administration of surfactant. So some really interesting use of different ways of administering surfactant. The technology around ventilation has changed light years since I was a trainee, both for invasive ventilation and non-invasive ventilation. And I think that's a really exciting area of development. And then lastly, steroids. So when Adam and I were trainees, we used to chuck vast doses of dexamethasone at babies to get them off ventilators. And it was disastrous. Studies show that it had a terrible effect on these children's neurodevelopmental outcome. So the pendulum swung all the way the other way. We didn't use it at all for about a decade. Now we've started using it again very judiciously. And certainly where I work, we're giving it prophylactically in tiny doses to babies less than 28 weeks in the first 10 days of life, because there's some good evidence to show it lessens the effect of the severity of chronic lung disease. So some really interesting things happening with regards to lung disease. But why does any of this matter to you? I want to highlight 3 areas, because I know that many of you that work in emergency departments, when you see the ex-prem coming into your emergency departments, your heart's already kind of sinking, and you think, oh God, what are we going to unearth here? And this will be complicated, and this will be a problem. But I think actually it's a real opportunity, because the care of these children doesn't stop when they go home. And actually, if you look at practices around discharging children from neonatal units, it's really patchy and not desperately well organised. So don't for a minute assume that all those children that you're seeing have been well organised in terms of their discharge planning. There's some really alarming data looking at how children who go home in oxygen are weaned off oxygen, how that's monitored, how are they screened for pulmonary hypertension. The American Academy of Paediatrics suggests that any child going home in oxygen should have a car seat test. So that basically you put them into the car seat, you know what it's like, they're all kind of scrunched up, monitor their oxygen saturations, and you check to make sure that they're being adequately oxygenated. Actually, a recent survey done in this country showed that less than half of neonatal units sending babies home in oxygen did a car seat test. So we don't know what's going on out there, and you may be the first team of healthcare providers that this family interacts with after they've gone home. So have your antennae wired up to a couple of issues that I want to highlight. I'm not going to get into the subject of next. Sorry, that slide was meant to be earlier. Necrotizing enterocolitis, just before I go on to the areas I want you to think about. Next, probably the one area we've made the least advances in. It's a rare diagnosis if you look at the whole cohort of premature babies, but when it happens, it's utterly devastating. It's utterly devastating because many of them die, but the survivors have a much worse neurodevelopmental outcome. So necrotizing enterocolitis is still a big problem for us. So I want you to think about three things when you see children that have been discharged from neonatal units, when you see them in the ED or in your general paediatric ward. Is their follow-up in place? What's their growth like? And are their parents coping? So NICE, which is our UK-based National Institute of Care Excellence, has now issued some guidance around the follow-up of babies who are born before 30 weeks gestation. And the single most important thing is that every family is entitled to a single point of contact. Because going home from a neonatal unit is a really frightening experience, and often there's all number of outpatient appointments and other things that they've got to engage with. So to have a single point of contact is their one kind of anchor in life. Now that's aspirational at this stage. I would hazard a guess that very few children's services have got this in place yet, but this is what we're aspiring to. So are these families plugged into a follow-up program, and is someone keeping an eye out for them? Interestingly, NICE now suggests that we follow up these children until they're 4 years old, which I think is really exciting. And they get an assessment by an educational psychologist when they're 4 years old. And of course, that's in the UK, the time at which children are going to school. And so that's a really timely potential point of intervention. Follow-up, I lead our follow-up service for our complex ex-prems. It's intensely rewarding doing follow-up. Because actually, if you pick up your 4-month corrected child who's starting to scissor a bit and look a little bit disorganized with their movement, introduce some really good focused physiotherapy, you see them 4 months later, and they're sitting, and they're starting to want to crawl, and the movement patterns have normalized. So we're dealing with a group of babies where actually intervening with appropriate use, particularly of therapy, is incredibly rewarding. But it's really important to do. We know in the UK that only about 50% of our ex-prem population are followed up to 2 years of age. Something happens to them, they move, they get lost, so you may be the first team they interact with. So ask them if they're plugged into a follow-up program, and if not, I would encourage you to resolve that for them. The other thing that I know as paediatricians, we often look at the ex-prem and we just kind of assume it's all right for them not to grow well. So some of the babies are they've had loads of formula milk, and they're kind of like really short, fat kind of baby. Other babies you see as ex-prems, and they're kind of small and skinny. Neither is acceptable. We now have a much more proactive approach to nutrition in the preterm baby. Parenteral nutrition is now started as the first line goes in, so by about an hour of age. The first drops of breast milk are administered now, ideally within the first 12 hours of life. So we're much more proactive about nutrition than we ever were before. We're starting breast milk fortifier much more proactively so that these children are adequately nourished. But nutrition in the ex-prem group is a really complicated area. So have your antennae tuned when you see these babies, and have a look at both length, head circumference, and weight, not just weight. Because we walk a tightrope between wanting good enough nutrition so they have a good neurodevelopmental outcome, but you're not throwing so much into the milk that you enhance their risk of necrotizing enterocolitis. So it's a very difficult tightrope to walk. And this is further complicated as more and more evidence is coming out about long-term outcomes of being premature. And I'm sure some of you have read about, there was a paper in JAMA only the other day actually, looking at a cohort of adults in their 40s who had been born prematurely, and very alarming differences in rates of ischemic heart disease. So we know these children are set up for metabolic syndrome, earlier onset of hypertension, and so on. So this is a difficult group. And what we do nutritionally in the first couple of years of life is absolutely fundamental to what happens later on. So growth, do not accept an abnormal growth pattern. This is no longer acceptable in modern neonatology. And then my final plea in my last couple of minutes is have a look at those parents. I'm constantly stunned in my follow-up clinic how much the parents want to come back to talk about their experiences, and how even 4 and 8 months after they've gone home, those experiences are still so vivid and so front of their minds. And these are some of the sorts of feelings that parents will talk about. We know from perinatal psychology support and our perinatal mental health services that, for instance, PTSD and depression is markedly increased in both parents who've been through a neonatal intensive care experience when compared with parents at the same time but whose baby was born at term and in whom there was a normal neonatal course. So all aspects of mental problems manifest themselves in these families. Obsessive compulsive disorder is much higher in this group, anxiety and so on. And this manifests itself in problems with bonding, problems in relationships both with the person's partner but also with their other children. Some of these families will have found themselves in conflict situations with us, and that's scarred them as well. So it's important to acknowledge this as a potential area and just ask a couple of gentle questions when you see them on your ward or in your emergency department. How are you coping? How are things at home? Because I think I wouldn't be surprised if you open a bit of a can of worms, and it's an opportunity to intervene and signpost to other help. So my message to you today is that actually this is a hugely good news story. These babies are doing far better than they were ever doing before, and it's about a good quality outcome. It's not just about survival. But you have a vital role to play, because the story doesn't end when they go home. The story is in fact just beginning. So the sorts of interventions, the sorts of interaction they have with you, and the opportunities that their interaction present for further intervention and support and so on, will continue to allow us to make the outcomes for these children better and better. Thank you.
Okay, we'll see what we've got from Twitter.
Thank you, that's really, really helpful. And I think a lot of general paediatricians are terrified of the ex-prems. I think the amount of referrals I get as a general peds reg from a GP that just goes, this is an ex-prem, and they haven't had the time to list that. And I also think that the family support is really essential. So we've had a few questions. One question is regarding juniors who, so in the sort of ST4 to 8 time in paediatrics, there are sort of more senior paediatric registrar years. What do you think we can gain from spending time in NICU for a non-NICU trainee?
Okay, so I mean, neonatology is a bit of a kind of Marmite subject. And as you know, I've spent a lot of time involved in paediatric training, and senior trainees will often say to me, do I really have to do more neonates? And I think it depends on the kind of career you see yourself doing. But I think if you're going to be a general paediatrician, I think having some senior exposure to a tertiary neonatal environment will massively enhance your confidence. But actually, I find that as neonatologists, some of the trainees I've learned the most from on my neonatal unit have actually been general paediatricians, because you are viewing children and families in a slightly different way. So we absolutely love having general paediatric trainees doing tertiary neonates with us. We see it as a huge responsibility to help improve their confidence, and usually the confidence issue is all up here, it's not in the real world. And actually we get a lot back. So I think the honest answer to that is, if you think you're ever going to work in an environment where you're going to be looking after newborns, don't shy away from it. Sort of face your fear and come and spend 6 months doing some tertiary neonates. I think you'll be surprised, actually. You very, very quickly get your practical skills up. And anyway, practical skills are the easy bit. It's the decision making. And actually, by the time you're a senior trainee, you're used to complex decision making. So it's just about applying it to a slightly different clinical scenario. So I don't think it's anything to be frightened of. Some neonatologists and neonatal nurses are a bit scary, but that's a different matter.
Not all of them. So another couple of questions. This is an interesting one. Does the NHS have the resources to provide educational psychological assessments for all NICU graduates before they start school? In Australia, we struggle to get cognitive assessments once the kids start school, let alone before.
It's a really, really interesting
got lots
question.
to say on that.
So yes, so we're actually just in the process of setting up our service. In this country, basically, if you derogate from a NICE guideline, you have to be able to explain to NICE why you're not applying it. So there is actually quite a lot of pressure on people services to implement NICE guidelines, which actually is really good, because because this issue around educational psychology support is, in this country actually there are not that many people who have the skill set to do this kind of work. So actually finding an educational psychologist is probably the first hurdle. And then there's senior psychologists, so funding it is a big challenge. But this comes back to why this should be done in a networked kind of way. It would be absolutely crazy if every other hospital felt they had to provide this. We need to network the support we do, and we're much better at this is a kind of complex niche area. If we could cohort them and say your perinatal centre would offer this kind of support, I think then we've got a chance of offering it at scale. But no, it's a huge challenge, and we're just starting that journey. We've just got our educational psychologist and our funding, so I'm really excited about getting going with it.
I know locally we've got an excellent physio who follows up, and she's
Yes.
looking a lot at risk stratifying. So because there's only one of her in our network, she's looking at identifying earlier which ones are going to benefit the most.
Yes.
Is that work being done from an educational point of view as well?
So, well, as things currently stand, nothing happens for these babies after the 2-year check. So at the moment, nothing happens. So the answer to that is no.
Yeah.
And that's the big worry. Because although I proudly showed you that 3-year data where a third were normal of the 24 to 25 weekers, they're normal by our current surveillance strategies. But are they normal when they go to school? And that's the bigger question. And I can see people shaking their heads. And I think our suspicion is a lot of them aren't. Now, interestingly, a lot of people used to think that we were creating kind of psychopaths for the future. And in fact, if you look at the ex-prem, they're actually shy children. They're children who don't socialize easily. They're often in the back of the classroom playing on their own. So they're not disruptive. But equally, they have other challenges within the educational environment that need to be addressed. So I think, I'm ashamed to say in this country, I think at the moment it's in the lap of the gods after they're 2. But hopefully, if we implement this nice guidance, we'll pick up more problems and deal with them proactively.
Yeah. Thank you. I think that's it from Twitter.
Anything from the room? Yep. I would agree. I'm currently doing an advanced training placement in NICU for 6 months at the end of my training, and I agree with what you say.
Good.
Even though the shift work is shortening my life, for sure. I'm getting a lot out of it.
Thank you, Camilla, for a great talk. I've got a practical question about fortifier. In my experience in Melbourne, it's very unit dependent. Yep. What's your local practice with timing of introduction of fortifier?
So, well, we're actually starting to introduce it earlier and earlier as we get braver and braver. I was incredibly anxious about this because, we were all taught if you change the osmolality of breast milk, you increase the risk of NEC. And I think there is some theoretical evidence about that, but probably that risk has been hyped up. So I tend to watch the urea. The minute it's persistently below 2, I would intervene with it. The guidance actually says less than 3. And actually, I defy you to find any baby on a neonatal unit with a urea over 3 unless they're a kind of renal failure or something. So no, I mean, most of our babies' ureas are horribly low. So I would watch the urea and then start with half strength. And it depends on your degree of concern. If it's not a bad baby and it's reasonably grown, half strength for 24 hours, 48 hours, and then go to full strength. There are lots of practical problems when you want to discharge that baby, though. So, sometimes it's about being realistic about what the trend in future feeding is. But actually, a lot of our babies, they go home with all this in place. And actually, then the mum gets going with her breastfeeding, and then the growth takes off, and you can stop the fortifier a bit later on. You just need to get them home, get everyone settled in. So sometimes there's a really good temporizing intervention. That's how we tend to use it here.
Thank you.
Anyone else? Oh, lots of questions. We've got plenty of time. I'll just pop in here.
Thanks again for a great talk. You showed in the initial slides the 22 weekers. Are you routinely resuscitating 22 weekers or giving a choice?
So really interesting and thorny issue. You'll be aware that nationally, so for instance in the Netherlands, they don't, I think 25 weeks is their cutoff. So there's really interesting variations between countries in their approaches to these very extremes of prematurity. We're not routinely resuscitating 22 weekers, but again, even between hospitals, there's variation in practice. But the data coming out about 22 weekers is definitely starting to force the conversation more to the fore, because actually their outcomes are not as dreadful as we always assumed they were. I mean, I have to say I've looked after a couple of 22 weeks and I can remember them like it was yesterday because it was so bad. But actually, other people are having different experiences with 22 weekers. So as with all these things, it's about assessing the baby when the baby's born, but it's on the back of hopefully having had the opportunity to have a really clear conversation with the family about risks and about, because 1 in 3 with severe disability, still very, very high mortality. So the answer is, I think more and more people are. I think 17%, we had about a 17% survival rate of 22 weekers in our 2017 data. Because we collect all our data in this country through a national neonatal audit program. And 17% of 22 weekers that were resuscitated survived to discharge. So the actual numbers are small and the survival is still very low. I'm not aware of anyone doing anything less than 22 weeks though.
Hi Camilla. I'm a general paediatric trainee and I very much enjoyed my time on tertiary NICU, but do you think we do a disservice to patients by letting general paediatricians cross-cover level 2 units?
I think the answer is it depends.
What's a level 2 unit?
So a level 2, so we're organised into 3 levels. So level 3 would be an intensive care unit. Level 1 is a special care baby unit. So those are kind of no respiratory support and no PN. And then level 2 sits in the middle. So some PN, some short-term ventilation, and some CPAP and vapor thermal optiflow. The honest answer is it totally depends. I've seen examples where you've got highly motivated paediatricians who actually genuinely take an interest in neonatology, but are keeping up their general paediatric skills, where out of hours you've got a separate consultant, middle grade, on call rota. And I've seen some of those outcomes are fantastic, where they collaborate really well with their tertiary centre, so they're not keeping babies for longer than they should do. They're shipping out the in uteros, the mothers, who are threatening to deliver under 27 weeks. In that sort of setting, I think it works brilliantly well. Where it doesn't work well is where people dabble, where your out-of-hours support is weak, where you might have a general paediatrician on at night who hasn't done neonatology for 20 years and you're expecting them to cover a neonatal unit, potentially assist an inexperienced registrar resuscitating a baby. So when it's done like that, you're not serving anybody's best interests, and that's just lazy and not fair. But when it's done well, I think, for like a 27, 28 weeker who pops out unexpectedly, who maybe needs surfactant and 6 hours of ventilation and then is on, a non-invasive form of ventilation, I think a level 2 neonatal unit is absolutely the appropriate place to be looked after. I don't know if you've had different experiences. I mean, I think we can all quote disastrous examples, but hopefully those are the outliers. And when people obey the kind of spirit of the rules in which our networks are meant to work, then I think it can work very well. But that's why we've got that figure of only 2 of 15 clinical networks where babies are born in the right place. We said we've got a lot of work to do. And sadly, it's often down to individual people's egos. I like a bit of neonatology, but the fact is you're not there 24 hours a day, 7 days a week. So you can't be there all the time doing this. So actually those mothers have to be shipped out, and even if it's just for the delivery and the initial stabilisation.
Okay, we've got time for one last question.
Hi, thinking about the paediatric ED.
Yeah.
Is there anywhere, you talk about signposting of parents who are struggling to cope. So my practice at the moment quite often is to admit these families as a kind of social admission under the general paediatric team. My trust doesn't have neonatology, so the neonatal service is provided as part of the adult trust. So thinking about where can we signpost these parents to? Do you have any practical kind of tips?
So, I mean, that's a very common problem, and we're lucky we've got perinatal mental health services and so on, but I think that what your story is very common. There are some fantastic parent-led, parent-run charities. So particularly organisations like Best Beginnings and Bliss have got huge numbers of resources online and then set up locally to support parents who are in this situation. And these are often run by people who've themselves been exposed to prematurity and neonatal intensive care. I think if you're particularly worried, then you might need to ask the GP to refer them for some form of counselling. Most tertiary neonatal units will have some form of perinatal mental health services. So if it's that serious, then getting that team involved might be appropriate.
Okay, that's all we've got time for. Thanks so much, Camilla.
Pleasure.
Thanks everyone for joining us, and enjoy your lunch.